Hello, hello. Welcome to your safety lecture. We're going to get started. Safety, as we know, is one of the most important aspects of nursing. This is critical because to provide safe care, we have to know what can be unsafe, what procedures we're doing, the things that can occur, and how we prevent unsafe situations. At the end of this lecture slides, you guys will be able to explain the rationale for vulnerable population being at risk for threats to safety, discuss common environmental hazards and methods for preventing them, describe how a nurse assists patients in managing safety risks in the home, discuss how individuals' developmental stage creates safety risk, describe ways to prevent procedure-related accidents, describe assessment activities that identify the psychosocial status of patients as it pertains to their safety, and explain the role of critical thinking and clinical judgment plays in planning care for a patient's safety needs. So what is safety? Safety is patient safety refers to the prevention of errors and adverse effects to patients associated with healthcare. As part of the healthcare team, professional nurses engage in all activities that support patient-centered safety culture. This is, of course, a definition through the World Health Organization, also known as WHO or WHO. The goal is to protect all patients. Who regulates safety? The regulatory bodies. That includes the Joint Commission and the Center for Medicare and Medicaid, which together they typically have the National Patient Safety Goals. And that is how hospitals or facilities maintain safety, and they track all safety events. The vulnerable population. So vulnerable population is a group of people who have the higher likelihood of experiencing poor health and may have additional barriers to accessing health services. In health, infants, children, and older adults are a vulnerable population. Individuals with mental health conditions, individuals with chronic illnesses, individuals who have difficulty communicating. That could be either from a disability, like if they had a stroke, if they have expressive aphasia, or it could be somebody that speaks a different language. Individuals who are low income or unhoused. So what are safety in the environment? So environmental hazards include things such as oxygen, nutrition, temperature, motor vehicle accidents, poison, fire, disasters, transmission of pathogens, and falls. Okay, so let's start at the top with oxygen. So oxygen is a basic human need. However, when we supply oxygen, it's considered a medication. There are a lot of safety components when we administer oxygen. How to safely use oxygen. In addition, what things can cause someone to lack oxygen in the environment. Example are like furnaces, fireplaces, stoves, carbon monoxide poisoning. Okay, let's move on to nutrition. So nutrition can be an environmental hazard. People have to have the knowledge of healthy foods, food safety and storage, safe preparation, and how to prevent food poisoning. As for temperature, we got to know temperature extremes. Too hot will burn, right? But too cold can also cause a a type of burn. So we have to take that into consideration. Motor vehicle accidents. So we have to remember to teach and educate about seatbelts or proper car seats, airbag use, helmets if they're motorcycles, and accident prevention systems. You also have to look at age-related for motor vehicle accidents. Example, older adults. Older adults have a decline in vision, hearing. They can have a cognitive decline. They might have physical changes in their physical abilities, which can increase the risk for a motor vehicle accident. So education on regular eye checks and avoiding night driving, taking the safest routes, avoid distractions, consider alternatives to driving. Poison. So poison sources such as medicine, cleaning products, gases, vapors, and lead poisoning. Exposures, usually swallowing or inhaling, or sometimes on the skin. It can get through to the bloodstream through the skin. Biggest thing with poison is we also have to teach our patients, especially older adults or those with chronic illnesses, how to properly take their medications, otherwise they can poison themselves. Fire hazard, so typically that's improper use of equipment and appliances, so we need to educate on fire safety, fire prevention strategies. Moving on, disasters. Though Arizona is rare to having natural disasters with the exception of the haboobs. But we have to look at things like floods, tornadoes, wildfires, tsunamis. These things can cause injury, death, homelessness, bioterrorism, so the use of biological agents as weapons. And then we have to educate on disaster preparedness. Transmission of pathogens, so any microorganism of producing illness. Transmissions most commonly through hands, so biggest thing is educating on hand hygiene and isolation precautions. Falls, so when a person inadvertently reaches the ground or fall, that's considered a ground level fall. Falls can lead to disability, loss of work, hospitalization, severe injury, and even death. Older adults are at the highest risk for serious injury or death from falls. The following slides will include factors that influence patient safety. This first slide will be your developmental stages. So think infant, toddler, preschooler. So most common hazards include injury, poisoning, aspiration, choking, drowning, burns. Safe environments include placing infants to sleep on their back on a firm mattress, educating parents, removal of dangers in the home, play areas, and using rear-facing car seats. For the school-age child, most common hazard includes environmental safety, fights, bullying, weapons, abuse, including physical, sexual, or psychological, and violence. For the adolescent, the most common hazards are substance abuse, alcohol, suicide, and opioids, though that's substance abuse or use. Cues include failing grades, changes in their dress behavior, absenteeism, isolation, changes in interpersonal relationships. For adults, the most common hazard is lifestyle habits, motor vehicle accidents, alcohol use, smoking, stress, and illness. And the older adult, most common hazards are motor vehicle accident, burn injuries, wandering due to dementia, and falls. Risk factors include physiological changes, polypharmacy, cognitive changes like in dementia, acute and chronic illnesses. This next slide talks about individual risk factors, so includes workplace culture, so safety culture, workers' attitudes and beliefs, resources. Example for risk factors are lifestyle choices, so the use of drugs and alcohol, dangerous jobs such as construction, utility repair, law enforcement. I could even say probably nursing now, considering how the environment is in the nursing field. Texting and driving, stress, anxiety, fatigue, and medications. Impaired mobility, so risk factors include muscle weakness, paralysis, abnormal gait, poor coordination, balance issues, falls, injuries. Sensory, cognitive, and communication impairment include cognitive impairments from dementia, delirium, and depression can alter concentration, which leads to orientation changes, leading to falls and burns. Visual, hearing, and tactile communication impairments such as aphasia, lack the ability to express needs. And then reduced health literacy, so unable to understand information to make safe choices. Economic resources, so risk factors includes being unhoused, depression, substance abuse, which can lead to injury, lack of access to health care, can lead to illness. And then lack of safety awareness, so lack of knowledge of home or workplace safety. So this is where it's crucial for you to do a good environmental assessment, but also to see where the patient is at in their understanding of making sure they are safe. So this next slide includes risks in healthcare agencies. So the biggest thing is your medical errors. When planned actions are not completed as intended or wrong plans of care are used. So error prevention and patient safety are emphasized. The Joint Commission has a Speak Up campaign. It's that see something, say something. The National Quality Forum, serious reportable events associated with surgical or invasive procedures, product or device, patient protection, so like an unsafe discharge or death or suicide, serious injury. Care management such as falls with injury, pressure injury incidences, central line associated blood infections, also known as CLABSI, environmental, radiological, or potential crimes. CMS call these never events, and it's similar to the serious reportable events or SREs. Procedural accidents. This is why it's critical to have a timeout before any procedure. Equipment related accidents. This is a huge one. We have to be trained to use the equipment that our facilities provide for us. Ooh, excuse me. Chemical exposure. This could be for patients and for us as nurses. So the hospitals use a lot of chemicals to clean, to make sure that places are sterile, and so we have to ensure that we're educated and knowing like how and what types of chemicals are being used in the hospital, or how we get that information in case there is an accident. Workplace safety again goes with that aspect of we may not know the exact procedures, but we need to know where to figure out to find the procedures on workplace safety. And then falls is a big one. Falls are completely preventable, but they are one of the highest causes of injury of somebody in a hospital, which is pretty severe, and falls are pretty much preventable. So in this slide, I'm talking about risk factors for falls or injuries to hospitalized patients. So we're going to go through some modifiable actions or things. Example, poor gait and balance that can be modified to improve and decrease the possibility of a fall or injury. Strength issues, right, like providing PT to strengthen the patient's muscles to help improve and then reduce the risk for falls. Visual impairments, while there are conditions that don't have it's not modifiable, there are some that can be modified. Problems with feet and or shoes, so finding proper fitting shoes. If a patient has diabetic neuropathy, ensuring that their sugar is controlled so that they don't have these issues with comorbidities, such as depression and osteoporosis. They're modifiable in the sense that osteoporosis is, once diagnosed, there's no cure, but they have medication that can slow it down and activities that can help slow it down. Use of medications that increase fall risk, especially in older adults. Lots of older adults are on different kinds of medications. And so while some medications are needed or are for life-saving measures, it is up to the healthcare team to ensure that there are no interactions happening, and that if this is the absolute only medication they can take, we are ensuring that the patient is safe so that they don't have a fall or injury. Orthostatic hypotension, we know that's a huge cause of injury, especially when patients come in from home with a ground level fall. Oftentimes, they are found to have orthostatic hypotension. Hazards in the home and community. Things like that would be, cluttery house, where a client can be at high risk for falling. And then a vitamin D deficiency. Vitamin D is directly needed to absorb calcium, and lack of vitamin D can cause that bone weakening, which can ultimately cause a fall or injury. So we're going to go through two different aspects of risk factors. So there's intrinsic, which is a person-based risk factor. So an advanced age, previous falls, muscle weakness, gait and balance problems, poor vision, postural hypotension, which is the same thing as orthostatic hypotension, comorbidities and vitamin D deficiency, and then the fear of falling. Those things increase the risk for a patient from having a fall. Excuse me. Extrinsic it's what the environment involves. So lack of stair handrails, poor stair design, lack of bathroom grab bars, dim lighting, or there's a glare, obstacles and tripping hazards, slippery or uneven surfaces, medication, and improper use of assistive devices such as canes, walkers, or crutches. Other factors which are intrinsic are competency-based. So if there's an increased use of restraints, improper fitting of assisted devices, improper supervision of the patient, decreased efforts by the hospital staff to mobilize patients, and then inappropriate or no footwear. These are all extrinsic factors. All right, so the following slides are going to teach you about using the nursing process for safety. So the first step of the nursing process is assessment, correct? Right, so we're trying to get as much information so that we're able to analyze the cues. So assess for patients' perception of risk factors, values and beliefs, concerns about being in healthcare setting, knowledge of how to adapt to safety risk, and then previous experiences with accidents. So you want to ask for medical history, right? We know that certain conditions, chronic illnesses, put anyone at high risk for falls. Medication history, we want to know if they're on different medications to see if it's gonna potentially interact or if it's going to cause something like the patient to faint from orthostatic hypotension. Psychosocial and cultural backgrounds, that portion is very critical because we have to know what our patient understands and how we're going to keep them safe. And so that's psychosocial background. We want to know how they are faring while they're in the hospital, because if they're not doing well, they usually want to refuse any more help, such as PT/OT, and it can be difficult for a patient to recover. Underlying conditions that create risk factors. I mean, hypertension's a big one. But there are other conditions that would increase the risk factor for falls or injury. You also want to do a physical examination or your physical assessment. Of course, you're going to assess cognitive status, gait, muscle strength, coordination, sensory deficit, and their cardiovascular status, if they're able to tolerate any movement or anything like that. We also want to assess developmental state and what risks are associated in that stage. Medications such as diuretics and sleep medications, because we know that these types of medications have an increased risk of falls, especially the diuretic if they're having to get up every so often. So we continue on the assessment. You want to assess the environment. Example, clutter, IV pumps, devices, bed position, gait belts, personal items, call light within reach, family members following hygiene guidelines, and risk for medical errors, and then disasters. The patient home environment, right? You want to assess for supportive care, basic necessities such as heating, cooling, caregiver availability. You want to do a hazard assessment. Is there adequate lighting, condition of flooring, safety devices, alarms? Are there side rails, safety bars in the bathroom, furniture placement, cords, rugs, risk for foodborne illnesses, and then fall risks. And then you have your psychosocial, so caregivers' knowledge and willingness regarding patient needs, economic status. Can patients afford assistive devices or medications? So what do we do with all that information? So we use that information to start prioritizing the care. We analyze the data, so all the information we collected from the health history, the physical assessment, asking the questions, is we have to use that information to create a plan of care. And the plan of care will look different for everyone. You have to use the assessment data you collect in order to hypothesize a priority problem. In the examples here, we're talking about safety. So the biggest, priority is risks for injury. We want to do all the things possible to prevent an injury from occurring. Impaired cognition, acute or chronic confusion, lack of knowledge, and risk for food poisoning. I think I said food poisoning. I meant risk for poisoning. Using that information, you're going to prioritize the care you want to provide. So if the patient's oxygen's at 88, you're going to put oxygen back on them. And that is your intervention. But if a patient is at risk for injury or risk for poisoning, what are interventions? A lot of the time, the interventions are your way to meet the goals. So what are measurable, realistic goals for either risk for injury or impaired cognition? Would be, examples like patient remains injury-free for 1 month. Patient adopts safety precautions at work in 1 week. Patient removes environmental barriers in the home in 1 month. And then we prioritize for which one we want to go through first. We always assess immediate risks of the patient, so developmental stage, level of health, lifestyle preference, and cultural needs. We also collaborate with patient caregivers and the healthcare team to reduce a lot of the safety risks. So once we have our priority problems, we want to take action. We want to implement to meet our goals. In risk reduction, a lot of the implementations would be in the realm of health promotion. So, example, reduce risk of falls and accidents, you want to teach safe driving tips, use of assistive devices, safe medication use, regular toileting schedule, install safety features in the home such as grab bars or smoke alarms, provide resources, neighborhood resources to maintain independence, maybe an occupational therapist consult, encourage independence, encourage annual vision, hearing screenings, and strengthening exercises. In the environmental aspect, we're thinking of oxygen use. We know it's flammable, food safety, fire safety, poisoning, using of medications, and or transmitting pathogens. There are some critical aspects of safety in the healthcare setting. Biggest one is your fall preventions, and you have restraints, the use of them, soft versus hard restraints versus violent restraints, how to use the side rails appropriately, seizure prevention, fires and preventing fires, but also how to put them out, and electrical hazard. We talked about falls, and falls is when a person inadvertently reaches the ground floor. Approximately 50,000 people die from falls each year in the U.S. It is a top adverse event in the healthcare setting, can result in injury, disability, or death. Comprehensive fall prevention approach includes a fall risk assessment of the patient conducted routinely until the patient is discharged. In Phoenix College, we use the Morse Fall Scale. The higher the number, the greater the risk of falls. We also use hourly or purposeful rounding, which we like to call the 3 P's, so potty, pain, and position. And going into a patient's room periodically, typically most facilities do hourly rounding, so every even hour the nurse rounds, every odd hour the tech rounds, and this helps mitigate falls. Having a color-coded wristband system, universally it's usually yellow. There are some outlier hospitals that use a different color to notate fall risk. Maintaining a hazard-free environment. So we know patient rooms can be small. They can get cluttered very easily. So ensuring that there is a hazard-free environment, and then universal precautions of falls. So those are all the things we can do to prevent patient falls, and we'll talk about those in the next slide. So what are some fall prevention interventions? What we like to call universal precautions regarding falls. One, you want to familiarize the patient with the environment. Have the patient demonstrate the use of their call light. Maintain the call light within reach. Keep the patient's personal possessions within their reach. Have sturdy handrails in patient bathrooms and hallways. Place the hospital bed in low position when a patient is resting in bed. Raise bed comfortably to height when the patient is transferring out of bed. Keep hospital bed brake locked. Keep wheels locked. Keep non-slip, comfortable, well-fitting footwear on the feet. Use night lights or supplemental lighting. Keep floor surfaces clean and dry. Clean up any spills promptly. Keep patient care areas uncluttered. Follow safe patient handling practices. All right, and so those are all your fall prevention interventions. In the next slide, we will move to restraints. So what are restraints? Patient restraints are devices or interventions used to restrict a patient's movement, usually to prevent harm to themselves or others or to facilitate a medical treatment. They are considered a last resort in healthcare and must be used ethically, safely, and with appropriate oversight. So again, restraints are allowed only if it reduces the risk of patient injury or injury to others, prevents interruption in therapy, and removal of life-saving equipment. It is not a solution or temporary means to provide safety. Always use alternatives before placing restraints. If required, use at least the least restrictive type. For example, soft mitts versus a limb restraint. Optimal goal for all patients is a restraint-free environment. There are different types of restraints. So physical restraints. Those are physical or mechanical devices, materials, or equipment that immobilize or reduce movements. And then there are chemical restraints. Medications such as anxiolytics or sedatives given to sedate or decrease the consciousness of a patient so that they're not acting out or being violent or whatever the reason is that they needed that chemical restraint. Complications can include from the immobilization include pressure injuries, pneumonia, constipation, humiliation, agitation, and death from the restrictive breathing and circulation. So what are we assessing when someone is on restraints? When it depends on facility policy, so you will always want to check your facility policies, but In general, you're taking some vitals, you're assessing the patient's level of conscious, their mentation, and assessing if they're ready to come off their restraints. You also are assessing each, if it's like a 4-point restraint, so you're assessing the wrists, the fingertips, the ankles, the toes. You're assessing for sensation, movement, making sure there are 2 fingers that fit between. You're also probably doing some vitals. And you're also assessing every time if the patient is ready to be removed from the restraints. What is critical to know about restraints? I think the biggest thing is you should use alternatives first. You want to always use an alternative before you moved on to restraints. Restraints, it's the last resort. It's the last thing we want to do to our patients. So we're going to talk about some alternatives of restraints. So one is orienting the patient to the environment. Supervision, sometimes a 1-to-1 or a sitter. Now they have the VR 1-to-1 thing. Give a diversional activity. That's a really good one. We have some diversional activities in where I work, because I work with a population of older adults who many have either acute confusion from like their surgical procedure to progressive dementia. You want frequent monitoring, de-escalation, timeouts, verbal interventions for aggressive patients, provide visual and auditory stimuli or reduce it depending on what is going on with the patient, teach relaxation techniques, exercise, ambulation schedules, attend to them frequently, offering toileting foods, pain management, using things to camouflage invasive lines such as IVs or JP drains, with clothing or using a stockinette. Evaluate the medication effectiveness. Discontinue bothersome treatment as soon as possible. Use protective devices such as hip pads, helmets, non-skid mats near the bed. Let's talk about side rails. Side rails are critical in nursing. They help increase mobility and stability when repositioning patients. They do increase falls, patients attempting to climb over them, get out of bed, and can get strangled or seriously injured. It is the most common form of restraint. Technically using 4 side rails, so 2 at the top, 2 at the bottom, is considered a restraint. It's not a restraint when 2 rails are up and the patient has a route exit to a bed safely and to maneuver freely within the bed. Used to prevent a sedated patient from falling out of bed. It's not for use on confused patients determined to get out of bed. So side rails assess patients' mobility status, responsiveness to instructions. Bed should be in the lowest position. Always no agency policies. Focus first on the cause and response to a new medication or dehydration or pain. Place a non-stick mat along the bed. Hourly purposeful rounding. Doing the 3 P's. 3 P's, potty, pain, and position. And then offering foods as well. So guys, this is the end of the lecture. I just want to say, just remember, it's all about safety. Safety is a huge and critical component of nursing. And from my understanding, safe care is one of the lower scoring materials in NCLEX. So please be sure to understand why it's critical to consider safety first. All right, y'all. See you guys in lecture.